Hello. Let's talk about the SDL titled colonic polyps. A polyp is a mass of tissue that protrudes into the lumen of the bowel. And with colonic polyps, the colon is the large intestine, colloquially. And it starts, remember, at your ileocecal valve down in your lower right quadrant. And right past that valve, you have your appendix, and that's at the bottom of your ascending colon. Then you have your ascending and then your hepatic flexure. That means that's where the colon bends on the right side of your body, where your liver is. And then you've got your transverse colon, and then it's going to bend again, and we'll call that your splenic flexure because it's on the side of the body where your spleen is. In fact, it's right next to the spleen. And then you have your descending colon, and then it bends again into the sigmoid colon, which has an S shape to it. And finally, the sigmoid colon will empty out into the rectum and then into the anus, and there's a series of valves there, lots of valves and sphincters, especially at the terminal part of that sigmoid colon going into the rectum. So a colonic polyp is a fleshy mass popping out into the lumen of the bowel, and polyps begin very tiny and they grow, kind of like a really bad zit if you've ever had one that just got, like, I don't know, like a dime size big. That would be like a sessile polyp, something that does not have a stalk and is attached essentially by its base to the lining of the GI tract. And again, a particularly deep pimple or an abscess, furuncle is a good way to think about what a sessile polyp looks like visually. It doesn't have a stalk to it. And if it does have a stalk, which is essentially a tree trunk, then it's termed pedunculated. And so sessile and pedunculated are two really useful terms that you'll use whenever you're communicating the nature of a polyp to a fellow physician to describe it adequately for them. Polyps do cause symptoms. They're going to present with one of three main symptoms or a combination. They're going to bleed, they're going to cause pain, or they're going to obstruct the flow of stool down through the colon. Bleeding's common on the ascending colon, and obstruction's common on the descending colon. We'll talk about that a little later, and it's simply because the descending colon, the left side, has a little bit skinnier of a lumen, a little bit more narrow a lumen, and so it's more likely that a polyp will just obstruct the whole thing on the left side than the right. We start off by talking about non-malignant polyps, and these are going to be benign polyps that have a very, very low, very minimal, if none whatsoever, risk of transforming into a cancer, which is a malignant neoplasm. Inflammatory polyps are also called pseudopolyps, and we call it a pseudopolyp, referring to the fact that it has no malignant potential. They're associated with several inflammatory bowel diseases or types of colitis, and they're incidental findings. But if you find one, you still want to biopsy it to exclude cancer. Then the text talks about this solitary rectal ulcer syndrome, which is a chronic disorder characterized by benign polypoid growth, and it particularly affects the rectum. And not only do you see inflammatory benign polyps in the rectum, you also may see a single solitary ulcer. And how the ulcer gets there is, well, think about trying really hard to poop. That's how the ulcer gets there. So the patients are going to present with mucus and blood per rectum on defecation. Other complaints are tenesmus, and tenesmus is kind of the constant lingering feeling that you have to poop, you know, so you'll just go and sit on the toilet for 20 minutes and you won't poop, but you'll still feel like you have to. That's tenesmus. Straining, again, kind of related to the symptom of constipation there. Altered bowel habits. Incontinence, that's whenever you can't control your bowel functions, and we also apply the term incontinence to the bladder, to urination, and many times incontinence is associated with some dysfunction of the autonomic nervous system. Remember that you have parasympathetics, not only where your cranial nerves are, but also you have a pelvic parasympathetic plexus, and your pelvic nerves are going to run into and innervate all of the different organs in your lower abdominal cavity. And so if you have a bad fall on your butt, maybe, you know, if you're in a car accident, that might really disrupt the path of some of those autonomic nerves going down to your important organs of defecation and urination, the bladder and the colon, and that leads to incontinence. And then also diabetic neuropathy is a very common cause of secondary incontinence, because when you're diabetic, you just get too much glucose in your nerves and they die. And then if that happens in your nerves innervating the colon, that can lead to an incontinence too. So endoscopically, in this solitary rectal ulcer syndrome, you see a solitary ulcer, shocker, and it's most often on the anterior wall of the rectum, 5 to 10 centimeters from the anal verge, which is an important landmark. We'll get there at the end of this lecture. Multiple ulcers are seen in a quarter of patients. The histology is not too important because this is the only thing in this SDL that really ulcerates the colon. I suppose you may have to differential this from ulcerative colitis, which can start near the rectum and then proceed proximally upwards the colon. And so I suppose that would be what they're really getting at by giving you the histology of this. And finally, a big complication of this combination of an ulcer and some polyps is that, well, due to all the straining, a polyp might just get blown out the back end of the butt, and that would be called prolapse. And I've got a picture of that. So if you don't want to see a prolapsed polyp out of the anus, then probably skip ahead a minute or two. Here it is in the setting of juvenile polyposis syndrome. That's what a prolapsed anal polyp looks like. And it can be a partial thickness prolapse involving the mucosa, or it can be a full thickness prolapse involving the mucosa and the smooth muscle. So again, if you see one of these, you're going to know exactly what's up, and then you're just going to have on hand in your mind a differential of things that could prolapse out the anus. Could also be a internal hemorrhoid. I suppose it could be a perforated bowel down there. Here's some images of solitary rectal ulcer syndrome, and what we're seeing here in the upper right is where I'll start. We got a cluster, a triad of 3 polyps right there, and then on the right upper quadrant of this 2x2 photo stack, we've got an ulcer right here adjacent to a polyp. And you notice that the ulcer's got this kind of pustular exudate on its surface, kind of like ice on top of a lake is how that exudate is sitting in that ulcer bed. And what that pustular exudate is a bunch of neutrophils, because this is liquefactive necrosis coating the bed of that ulcer. And we know that neutrophils have lytic enzymes that once they release those proteolytic enzymes and those oxidative enzymes, neutrophils will just melt everything around them. And so that's what's going on in this ulcer bed. And if we look at the histology of one of these ulcers or polyps specifically, you see a really big, thick lamina propria, and you don't see a ton of glands, and that's going to differentiate a little bit from UC. And I think that in UC, you see a way heavier immune cell infiltrate as well. So that's solitary rectal ulcer syndrome. This is a good table. I suppose now is as good a time to talk about it as any during this video. GI polyposis syndromes. First off, all of them involve tumor suppressor genes, so that's not going to be a question. Second, there's one that you get when you're really old, and that's called Cronkite-Candida syndrome. And that one actually we don't see any inheritance pattern in, and it's characterized by specific symptoms of nail atrophy and skin loss. Nail atrophy, like the fingernails, right? So that's a really peculiar symptom. So you're not going to have a problem diagnosing that. Peutz-Jeghers Syndrome also has another very particular syndrome. We'll see that in a few minutes. It's got macula of the skin. And remember, a macule is a flat spot on the surface of the skin. It's not raised, it's not indented, it's just totally flat. Cowden syndrome and Banyan-Ruvalcaba-Riley syndrome both present with macrocephaly, which is Jimmy Neutron head. And there's a few clinical symptoms to set them apart, but they involve the same gene and they involve the same related cancers. And that leads me to my final point, which is that you look at this SDL and you're like, where are the questions going to come from? What are they going to ask? And well, I would think that minimum one, probably two questions are going to be, what's the related cancer? Because all of these syndromes that we're going to talk about starting now do have either spots of preferential metastasis or related primary tumor sites. And in Peutz-Jeghers, for example, you're more prone to be getting breast cancer, lung cancer, pancreatic cancer, bladder cancer. So those sorts of things are testable just because you can work a multiple choice question out of them. Let's discuss Hamartomatous polyps now. Remember what a hamartoma is. It's essentially not a tumor, but it is a tumor. We're starting to call it a neoplasm now because lately some studies have demonstrated clonality within hamartomas. And a hamartoma is essentially a swath or a territory of atypical cellular architecture without dysplasia or really bad nuclear changes. So the cells are normal enough, but they're still not where they should be. And so that's what we're really referring to when we say distorted architecture. You might see some squamous epithelial cells, for example, like way deep under the skin. That would be an example of a hamartomatous change to me. So juvenile polyposis syndrome is an example of a colonic polyp syndrome involving hamartomas. And juvenile polyps are particularly, well, the reason why they're hamartomatous is because you see these cystic spaces absolutely where they shouldn't be. There's just too much mucin in these cells. And there's a whole lot of glandular cells too, a whole lot of goblet cells producing mucin. So the polyp's going to have a smoothish outside to it. And if you slice it open one more time, you see big glands with epithelial hyperplasia, creating a cystic architecture due to all the secretions that are coming out of those hyperplastic epithelial cells. So that's what we're looking at when we talk about juvenile polyposis syndrome. The majority of polyps are located in the rectum and present with rectal bleeding. So that's your lead into the question. It's autosomal dominant. What they really want to know too is what's the gene involved, and I'm referring really to our in-house exams on that. What they really want to know is what gene is mutated. So in the case of juvenile polyposis, it's going to be the SM84 or BMPR1A gene. Both are involved in the TGF-beta signaling pathway. What is TGF-beta, transforming growth factor beta? Well, it does a whole lot of things, but something that it does to every cell is it helps them regulate. It's a pro-regulatory molecule. So when TGF-beta binds to a cell, it's going to make that cell a little bit more prone to say, whoa, slow down at the end of G1 and reassess everything and look at its internal state. And it kind of encourages a feedback loop. And so at the end of G1, if the cell's damaged, it can commit apoptosis. But if the cell's stressed, well, then it can speed up and go through S even quicker and start popping out growth factors. And then if it's normal, it'll just keep doing what it's doing at the same rate. So TGF-beta raises cell awareness by locking it in that G1 and giving it a chance to see what's going on. So if TGF-beta locks your cells into G1 and you one cell receives a mutation in the TGF-beta pathway, then what happens is that the cell no longer has the same instigation to lock itself and stay still for a minute and check out what's going on in the cell. And that period between G1 and S is when a lot of cellular housekeeping goes on again. If the cell needs to go into apoptosis because it's damaged, that's when it happens. So if you don't have TGF-beta, you don't stop in between G1 and S, you just keep going, and that's how cancer cells that do accrue these TGF-beta mutations just snowball and roll down a hill. So again, these are also called Hamartomatous polyps because they're not malignant. They really don't have malignant potential. And there it is in this paragraph at the top of page 5. No dysplastic changes are present. You're really looking for those characteristic cystic spaces. That's the big thing to highlight. None of the other tumors or polyps in this SDL have those cystic spaces. Peutz-Jeghers Syndrome. Peutz-Jeghers Syndrome is going to give you some polyps in the small intestine. And again, they're going to be hamartomatous polyps that are benign. They're not going to transition into a cancer. They'll present with complications of obstruction. You might see one fall out the butt. Anemia is another common presentation of all these different colonic polyps because, well, again, once it starts bleeding, if you don't notice it's bleeding, it can just bleed, and then all of a sudden you look up and you got a hemoglobin of like 8.5 or something, and like 11 or 12 is normal. And intussusception is another possible complication, especially in children, because that polyp is going to present a potential lead point. That's how it's phrased, for telescoping of the bowel. And that's what intussusception is whenever a segment of the bowel kind of pops into another one. Or also think of like those Russian stacking dolls, you know, or like stacking cups. If you ever did that in PE in like 4th grade or something, like that's what your bowel's doing. And it can only do that if it's got like a handhold or a grip, you know. And so the part of the bowel that slides over the other part of the bowel, because that's what normally happens during peristalsis, well, normally it'll just slide right back off. But then let's say that you have a swollen lymph node in the bowel, like a Peyer's patch, and it's just big because it's filled with B cells because of an infection. Or let's say that you have a polyp. Again, that represents a bump in the mucosa of the GI lining. And so that bump right there, like I'm just bumping up my finger like that, whenever your bowel goes to slide over some bowels, like, because that's what happens in peristalsis, it'll go to detach itself, but it won't be able to like pull out, you know, because it's getting stuck on that bump presented by the polyp or the inflamed Peyer's patch. And that's how intussusception gets started. That's why we see intussusception with adenovirus commonly in kids, because the virus, again, gets into the small bowel and gets into some of the mucosa-associated lymphoid tissue down there. And then the kid's bowel goes and it's doing bowel things, and it just gets stuck on that big swollen lymph node. Back to Peutz-Jeghers. Because this is the only one that's got small bowel involved in this SDL, I was remembering it with there's a J in Jeghers, there's a J in jejunum, and that's good enough for me. And you're also going to remember the blue to dark brown pigmented macules around the mouth, the eyes, the nares, and the buccal mucosa. This is the only thing in this SDL that does this. You're going to spot this from a mile away. You just need to remember it's STK11 mutation, and you need to remember it's got increased risk of some extraintestinal cancers, gastric cancer, pancreatic, breast, and ovarian there. And so I got nothing to tell you about that. Just memorize it. Again, it's autosomal dominant, STK11. It's a tumor suppressor gene. How do we know that? Loss of function mutations are found in the cancers. The polyps are most common in the small intestine. They're large and pedunculated with a cerebriform appearance. What do you think that means? I think it means that it kind of looks like a brain if you're looking at it grossly. Histologically, We've got a lot of smooth myocytes that originate from the muscularis mucosa and form tree-like branching within the lamina propria. That's characteristic. And arborization, arbor, kind of being a Latin word for tree. I think it's Latin. It's a tree-like growth of smooth muscle into the body of the polyp. And that's helpful in distinguishing Peutz-Jeghers polyps from juvenile polyps, which have what sort of histology? What do we see? Cystic spaces, yes. So let's take a look at Peutz-Jeghers quickly. Here's your macules again. But what do you think it is? Kid's got GI symptoms, Peutz-Jeghers. And here's an example on the right. It's on the gums. It's on the gingival mucosa. It can be on the buccal mucosa. That would be the inside of the cheeks, like right there. And if we take a look at the small intestine, here's a sample of some of the polyps you might see. So cerebriform, I can kind of see that. You know, it's well vascularized, this one especially. And then this one down here in the lower left, you can kind of see, again, it's a veiny look to it. It's kind of cerebriform. And right here, what we're doing is we're just lassoing this thing and cinching it off, essentially. And again, they're hamartomatous because they're just a benign growth of tissue where it shouldn't be growing. So that's why we call it hamartomatous. One more time, it's totally benign and it's tissue that's just growing where it shouldn't be. Here's the histology looking at the arborization of smooth muscle. This is a real low power macro look at it. And I'm trying to outline the smooth muscle that I see in some green. And you can really tell that it's branching out like exactly how a tree has branches. That's how the smooth muscle core of this Peutz-Jeghers Hamartomatous polyp is branching out into the, what's a good word to use? Cortex of the polyp. So that was Peutz-Jeghers syndrome. Now let's talk about Cowden syndrome and Banyan-Ruvalcaba-Riley syndrome, which are both autosomal dominant and both are associated with loss of functions in PTEN, a tumor suppressor gene, and both of these are associated with macrocephaly. And so macrocephaly is going to be head circumference above 95th percentile for height and weight and age. And macrocephaly, this child here, you can see it best in B, has some macrocephaly. So it's not something that's immediately apparent until you actually measure it. And so that's the clinical side of things. You got to know what you're measuring and have a tape measure on handy to do it. And well, the fact that you know that and can do that is going to be what makes you a doctor and not just some dude on the street who can say, oh, hey, that kid's got a big head. So once more, we're seeing association with different extracolonic malignancies, breast carcinoma, follicular carcinoma of the thyroid, and endometrial carcinoma. So again, that looks like test question city to me. That's like one of those is the right answer, and then you're going to get hit with 3 or 4 other different cancers. So I feel like that's got to be one question from this SDL. Other symptoms are going to include lentiginosis of the genitals and benign mesodermal hamartomas. So again, the concept of hamartoma, abnormal architecture, you got a lot of cells growing where they shouldn't be, and something that would fall under the category of a benign mesodermal hamartoma would be a lipoma, hemangiomas as well, because again, these are benign tumors that aren't going to grow into anything. 9.999 times out of 10, a lipoma is not going to turn into a liposarcoma. It's going to stay a lipoma. And I also had an example right here on the right side of the screen is a lipomatous mass that's grown across the entire length of this affected child's back. And even though it's benign, you can certainly imagine that's a great impedance to quality of life. And So the recognition of these problems as early as possible is certainly to be strived for on our part. Lentiginosis, that's just spots, and you can see a lentigo on the skin, and that's a sunspot basically. Some people will have like these small, maybe like a couple millimeters, just dark macular, again that means flat spots on their face, and it'll be like because they tan a whole lot, and so you could say, oh well, that's just a lentigo, it's benign. Really impressive, those doctor words, Will. So the gene P10 encodes a phosphatase. Now, is that going to phosphorylate or dephosphorylate a target protein? And I hope you said a phosphatase is going to dephosphorylate a target protein. And so it's involved in cell cycle regulation. And if you have this particular mutation, it's going to lead to an overactive phosphoinositol tris kinase, AKT pathway. That's protein kinase B. And that's a pro-survival pathway. And so if you lose the ability to regulate that pathway and it stays always on, well, then the cell is always in, I need to grow, 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 and divide mode. Not much else to say about those two kind of minute syndromes. Cronkhite-Candida syndrome is characterized by multiple polyps of the GI tract. It's non-inherited, it's sporadic. That's what non-inherited means. 75% of patients are of Japanese descent, so there's the test question right there. Associated abnormalities include nail atrophy and splitting. There's the test question right there. Hair loss, cutaneous hypopigmentation. That's if they ask you about it. I don't see much going on there besides just make the diagnosis. Okay, so that was Hamartomatous polyps. Now we're talking about hyperplastic polyps. And I guess thinking out loud here, I suppose, or I'm rationalizing that the way that they're different is, remember we said a hamartoma is essentially abnormal architecture, which means some cells are growing where they shouldn't be. Well, my thinking is that in a hyperplastic polyp, the cells are exactly where they ought to be. You know, none of them are out of place. They are locationally correct. However, they're just multiplying like mice, like rabbits, you know, so that's the hyperplastic element of it. They're where they should be. There's just too many of them. So that's the difference in my mind between hamartomatous, hyperplastic. The chief significance of colonic hyperplastic polyps is that they must be designated from sessile serrated adenomas, histologically similar lesions that have malignant potential. So you're going to see this one lesion on endoscopy and you're going to say, well, okay, that's pretty lumpy, bumpy on the outside. It could be one of two things. It could be benign or malignant. And indeed, the hyperplastic polyp is the benign version of what you're looking at. And then the sessile serrated adenoma is the potentially malignant version of what you're looking at. So you need to biopsy it and make the diagnosis. That's what this paragraph is saying. Now, hyperplastic polyps are serrated. And serrated, well, that means sawtoothed. And we've seen this word before in your serratus anterior, which is like your boxer's muscle. And if you've got a distinguished one, then it really does kind of have this angular sawtooth appearance. And that's the sort of sawtoothiness we're seeing in the surface epithelium of a hyperplastic polyp. It's going like up and down and up and down and up and down and up and down. And you can kind of see it's got a toothiness to its epithelial component. It's like bang, bang. There's crevices in between individual lumps of epithelium. You can see it. Like even when you cut a gland axially in the z-axis, you can still see the sawtoothiness of that gland. Like that's a tooth. That's a tooth. That's a tooth right there. Like that's a tooth. Lord, that thing's jagged right there, you know? So it's like, that's what we're saying when we're referring to a sawtoothed appearance. And so what the last paragraph said is that this tumor and one other tumor in this SDL had this sawtooth pattern. And so you better be able to tell them apart because that's going to be a test question. And what really, really makes your diagnosis histologically is that in a hyperplastic polyp, you've got serration that's restricted to the upper 1/3 of the crypt of the glands of whatever region of colon is involved. So here's a hyperplastic polyp. Here's what a very low power section looks like. Again, you get closer, as we'll start on this right hand photo, and you can tell that the lining of this tumor looks like chainsaw teeth. Again, there's protrusions and inlets and protrusions and inlets. It pops out, then it pops in, then it pops out, then it pops back in. So that's our serration of the surface epithelium of this tumor. Another beautiful section. Notice that the glands, however, when you get really deep down in here, and I'm talking like that region here that I've circled in green. Look at that region now. If you were to block everything else out, those glands look pretty normal, don't they? Right. So that's why this is our benign serrated polyp. And remember, we said it's only serrated at kind of the surface epithelial level. Well, that's exactly what we're seeing here. We're seeing, well, it's going out, it's going in, it's going out, it's going in, going out, going in, out, in, out, in, out, in, out, in. You get it. Sawtooth, serrated. Again, it's really important to note that the surfaces of hyperplastic polyps are serrated, but the cores of hyperplastic polyps are not serrated. And that's what makes your differential between this and a sessile serrated adenoma, is that the whole crypt is going to be serrated, not just the top. Even down, down, down in the core of this polyp, you're seeing the sawtooth appearance. Getting a little bit of cart before the horse here because we haven't talked about that particular malignant polyp yet. So a hyperplastic polyp, just to wrap it up, composed of mature goblet and absorptive cells that show no dysplasia. And the reason why you see this serrated surface architecture is because epithelial cells and goblet cells are just dividing, and they're pushing each other upwards. And that's creating the lumpy, bumpy topography that you observe on these tumors. So adenomatous polyps are roughly 10% of colonic polyps, and they're precursors to colorectal adenocarcinomas, which are malignant cancers. Anytime you see carcinoma, you know it's a malignant neoplasm. So thinking back, what makes it malignant? Well, it's invasive. It's encroaching outside of the basement membrane into surrounding tissue, where possibly it's metastasized. If it's metastasized, then it's automatically, by definition, invasive. Incidence of these adenomatous polyps as high as 50% by age 70. That's a pretty impressive statistic. You don't need to know too much about what they look like grossly because there's such a variation within gross polyps. Their surface resembles velvet or a raspberry. I take that to mean it's pretty smooth and obviously erythematous. What you do need to know is the histology, because the biopsy is how we make the diagnosis, not how does it look to your eyes grossly. The histopathologic hallmark of adenomatous polyps is dysplasia, so that should make sense. If it's dysplastic, then it's trending towards malignancy. These changes are most easily associated or appreciated at the surface of the polyp, and they're evidenced by nuclear hyperchromasia, so dark, pigmented nuclei. Picking up stain because they're actively dividing and there's a lot of protein inside the nucleolus associated with that DNA unwinding at the time. Elongation of nuclei, mitotic figures also. So that's what we mean by dysplasia. There's some histology here of different gross tumors. There's our tubular adenoma and our villus adenoma. And I feel like you could just answer that question on a gut call. You know, if I showed you both of these and I said, which one is tubular and which one is villus? The tubular one definitely has glandular tissue to it, way more glandular tissue, because the purpose of that tissue is to secrete things, versus a villi, which is an absorptive structure. That's how you recognize it. If you understand that the purpose of a villi, a single villus, is not to push anything into the lumen, but rather to take in what's already there, then it's like, okay, those cells here on the right aren't as thick because they don't need to be producing anything. But then you have way thicker lumens and glandular histology here on the left because, well, that's secreting something. Here you can tell the dysplasia very easily. It's kind of a cutoff from left to right in the middle of the image. Right here on the right side of this photo, there's your dysplasia. Again, we're looking at hyperchromatic nuclei. They're basophilic too, because the basophilic refers to anything that picks up hematoxylin, which is the H part of H and E, and that's the purple color of the purple and pink. And nucleic acids like to pick up that H part, and proteins too. And so the more proteins that you have going on in a cell, the more it's going to pick up that H and stain basophilic. And it also says decreased mucin production. I had to look and see what they were referring to with that, but I figured out that right here, you know, you're seeing all this stuff kind of on the surface of the epithelium over here, and it's basically filling in the potholes in the epithelium, and it's all this stuff in here, and that's the mucus that we're looking at. And then we look over here, and it's dry as a desert. There's nothing on top of those cells. So that's what they're referring to with mucin production, and being able to observe that histologically. So there are 3 types of adenomas, and they're named essentially by their gross and histologic structure, and they correlate. And there's tubular, tubulovillus, and villus. And I did not include those in my PowerPoint images for this particular lecture because I think it would just be cruel and unusual punishment to say, okay, is this a tubular or a tubulovillus colonic adenoma? You know, I don't think they do that to us. So if they do, I'm taking the fat L on that. Now we get to sessile serrated adenomas, and this is the boy that we had to differentiate from the hyperplastic polyp. Remember, because the hyperplastic polyp is benign, but a sessile serrated adenoma has malignant potential, and they're both going to be characterized by a sawtooth epithelium. And the big difference is that the hyperplastic polyp has that sawtooth appearance on top of it, kind of like hair on its head. But then the sessile adenoma, the whole thing has sawtooth all the way down to the bottom of the crypts of all those different glands. It has that sawtooth epithelial appearance. And it's associated with a couple of genes, namely MLH1, which is a mismatch repair gene. I think also might be defunct in Lynch syndrome. And it's also associated with BRAF. And that's actually information that I pulled from the previous SDL number 14, because it was mentioned in that text that hypermethylation phenotype polyps do express BRAF often. So I threw it in my notes for this SDL because of the overlap and because I didn't want to get that question wrong if it got asked. So these sessile adenomas do not show dysplasia. So you can't use dysplasia to tell this apart from a hyperplastic polyp, but you can use dysplasia to tell an adenomatous polyp apart from all these other polyps. Finally, before we look at this, there's something particular about the crypts of the affected glands in a sessile serrated adenomas. The basal portion of the crypt is branched, leading to a boot shape or an L shape. So let's take a look at what that looks like. This is a sessile serrated adenoma, and on the left side of the screen here, you've got a nice example of an L-shaped or a boot-shaped gland. And what that indicates, again, is that the basal or the floor part of that gland has a branching structure to it. And this can manifest as glands that appear to be lined horizontally or projecting into and out of the screen whenever you're looking at histology. And I've circled horizontal glands here in green because this is going to be another marker of a sessile serrated adenoma compared to a hyperplastic polyp, which will tend to all be in the same plane. For reference, let's look at a hyperplastic polyp one more time. Notice that somebody cut this slide and all of these glands are oriented in the exact same direction, right? They're all going through the screen. I can't see one gland on this screen that's going left to right. Same thing here. This is a hyperplastic polyp. All of these glands are going in the same direction, down the z-axis, into and out of the screen. I can't see one gland here that's going left to right or up and down on the screen. Another hyperplastic polyp, relatively same thing. They're all radially spoking outwards from this hub in kind of the same direction. Now here's your sessile adenoma, and you're just like, okay, there's a horizontal gland, there's a horizontal gland, there's a horizontal gland, here's some horizontal glands. They're all over the place, yo. And it's because of that L-shaped gland architecture that we'll zoom right back into here. And the premise of it is if you just take that L and rotate it to where the base of the L is pointing towards you, well, can you imagine how you get these horizontal glands? It's because that, again, the foot of the toe of the boot is pointing towards your screen. That's it. So there's that, and then there's also the continuity of the sawtooth pattern deep into the crypts. And again, the sawtoothness is like there's gaps in between cells. And yeah, I mean, I just traced that sawtooth pattern all the way to the base of that crypt. So that's something that you'll see in a sessile serrated adenoma that you won't see in a hyperplastic polyp. And one more time to reiterate, the reason it's got that sawtooth serrated appearance is because these epithelial cells just keep proliferating and dividing unchecked. And so they're, right here is a great example. I'll outline this in yellow. They are just pushing one another upwards and out of the way as they continue to divide. One more time, no dysplasia in that SSA, the hypermethylation phenotype. Let's get on to the traditional serrated adenoma. This is typically left side predominant. And so I want to bring up quickly left side predominant and right side predominant cancers. Here we are. So the sessile serrated adenoma, I'm going to use a different color. I'm going to use true blue, is predominantly located in the right colon, right? So what that means is that the number one presenting symptom with a right-sided or ascending colon tumor is going to be bleeding. Now you can contrast that to a left-sided colonic tumor, which is going to present with the number one symptom of obstruction. And so I want to make that clear, and I got this from Goyan, that the reason why right-sided polyps bleed is because the lumen of the right colon is bigger. So the polyp has more room to grow into that lumen and stick out and protrude into the lumen. And so let's say my thumb is a polyp and it's sitting in the lumen. And let's say some poop comes by, right? Well, like if you're a polyp getting smacked in the face with a big log, Like, that's the equivalent of like tying you to a train track and just letting a train roll over you at like 5 miles an hour, you know? Like, just because it's going slowly doesn't change the fact that you're getting crushed by a train. So that's kind of the experience of what it's like to be a polyp in the pathway of feces. And if that happens enough times, yeah, that polyp is just going to get beat up because it's sticking out into the lumen. And it's sticking out into the lumen because it's got enough space to do so, because it's on the right side where there's a big lumen to start with. Check. So, left-sided, the colon's smaller on the left side. The lumen is skinnier. So as a result, growths in the left side of the tumen tend to be annular or sessile. What does that mean? That means they're flatter. That means they don't stick out into the lumen. Why not? Because they don't really have enough space to grow out and do that. So as a result, symptoms of a left-sided colonic mass. The number one symptom there is obstruction. Because if you've got just this big lesion inside the wall, or an annular lesion that's like a ring, well, whenever you go to push some poop through there, you can't, because of the mass that is part of the wall. And I'm not saying you can't have a polyp that bleeds on the left side or a polyp that obstructs on the right side, but let's face it, this is boards, this is standardized testing. They're going to treat it like that. And if they say, oh, hey, it's obstructive, then it's going to be a left-sided, not a right-sided. I don't know how they can ask that question, but I have accrued that information, and I want to pass it to you. So let us finish up quickly by discussing the traditional serrated adenoma, which is a minutia of colonic polyps that appears in the elderly. It is left side predominant. It does tend to be pedunculated, so we'll have a stalk on it, a stalt on it. Again, I'm saying no rules, just trends. It does have a serrated architecture. It's going to have a pseudostratified epithelium without dysplasia. And it's going to have a it's going to have a hypermethylation of the DNA repair gene MGMT, which has the function of removing alkyl groups from the O6 position of guanine. So guanine's a base. It's the G in our DNA and RNA. And if you have this particular mutation that leads to a traditional serrated adenoma, what that means is that you get some base mispairing. So guanine will pair with thymine if it's not alkylated properly. And when guanine pairs with thymine, well, that can put a wrench in the middle of a CG island, because you got a lot of guanine in CG islands. So why are CG islands important? Well, CG islands are kind of like light switches, like off, on for promoters. And what's a promoter? Well, a promoter is a part of a gene. And a promoter is kind of like the light switch for that gene, right? So it's like you have a light switch for the light switch. Whenever the promoter's on, the gene gets transcribed and the protein product gets made from the RNA produced by the gene. But whenever the promoter's off, none of that happens. Now, whenever a region of DNA is methylated, it doesn't matter what promoter binding proteins are in the area. They can't bind it because the DNA is coiled tightly. It's methylated. When DNA is demethylated, well, then it's unwound. So you have access to the promoter. So that's what I mean by saying that the CG islands, by controlling methylation patterns, are like on switch, off switches for the promoter on switch, off switch. You've got a risk of colorectal cancer for those, any of those colonic polyps. Well, I won't say any of them. I'll be more specific than that. You have a risk of colorectal cancer associated with Adenomatous polyps, tubular adenomas, sessile adenomas, and traditional adenomas. And traditionals have a stalk and sessile do not. Clinical presentation, often hematochezia, that means red stool, which can be associated with anemia. So part of your workup is always going to be complete blood count. If it's an acute setting, you're thinking airway and then fluid replacement first. Might have a diarrheal syndrome. And then there's a small blurb on familial polyposis syndromes, which we'll talk about in the SDL regarding those syndromes. But other than that, thank you for listening. I'm going to go through in my mind and recap this last section here. So we've got non-neoplastic and neoplastic polyps, correct? And then our non-neoplastic polyps can be either just out of nowhere, you know, just a random inflammatory polyp, a random hamartomatous polyp, or they can be part of a syndrome. And then we also have hyperplastic polyps, and that's a variant of a non-neoplastic polyp. So we've got three types of non-neoplastic polyps, really. We've got inflammatory polyps, which are just highly associated with generalized inflammation. We've got hamartomatous polyps, which means that you've got a bunch of cells in the wrong place. And then you've got hyperplastic polyps, which just means you've got a bunch of cells, like capital B bunch of cells. They're not in the wrong place. There's just too many of them. Then we have neoplastic polyps. And technically, what that means is that we've got polyps with potential for development of malignancy. So we've got adenomatous polyps, which we name by their generalized structure. They're either tubular or villous or tubulovillous. And then we've also got some serrated polyps, and our serrated adenomatous polyps can be either sessile or traditional, which means they're going to be pedunculated on a stalk. So we're going to name them partly based on their gross appearance, partly based on their histology. And one last time, I just want to emphasize, because I know I didn't do any extra work into this. Again, you've got a villous adenoma here. Note the slender projections. Why are they slender projections? Because you're not secreting anything. Your function of a villus is just to absorb, so it can be thin, because you're trying to maximize surface area to volume ratio. You don't want it to be this big, thick thing that takes up a lot of mass. You'd rather have 5 villi in the place of 1 secretory duct, right? So because the function of villi is absorption, they're smaller and they're thinner to fit more in a given area. So take that into account and just apply it. You don't have to sit and look at 10 practice images of is this a tubular? Is this a villus? Is this a tubulovillus? No, just think about it and you're going to know the answer. I believe in you. I trust you. You're going to get all this histology right on this exam. Now go do it.